Hello, everyone, and welcome to today's edition of Patcast. Today is April 21, 2020. Hope you all are keeping safe amidst these challenging times. I am Rifat Mannan from Philadelphia, and I'm remotely joined by my good friend Emilio Madrigal, who is in Boston. Today, we are excited to welcome Dr. Ashley Cimino-Mathews, who is an associate professor of pathology at the Johns Hopkins University in Baltimore. Over the next 1 hour or so, she will be presenting a slide seminar on papillary lesions of the breast. And as always, please feel free to post your question or comment on Facebook and YouTube chat window, and Dr. Mathews will answer it towards the end of the session. And thank you everyone for joining. Thank you, Dr. Cimino-Mathews, for being here today. And over to you now.
Great, thank you. Thanks to Emilio and Rifat for the invitation. Again, I'm Ashley Cimino-Mathews. It's really a pleasure to be with you all this morning, my time. And again, I echo what Rifat said and wish you all health and safety in this time. So in this next hour or so, we'll take a look at papillary lesions of the breast. It's difficult to do papillary lesions in 60 minutes or less, but we'll cover most of the basics. And I want to start with a slide to give the underlying scaffold, if you will, to all of these lesions, and the way that I approach these in thinking about the distribution of the myoepithelial cells within the lesion. And I kind of keep these images in my mind as I take a slide and decide, okay, where on the spectrum of papillary lesions does this particular lesion fall? So the first, let me make sure I can control my slides for you. Here we go. So the underlying architecture of a benign intraductal papilloma is an intraductal proliferation. Here, I'll make a little laser pointer. An intraductal proliferation with fibrovascular cores projecting into this dilated duct space. And the myoepithelial cells, which I've drawn very fancy as little yellow dots, the myoepithelial cells are present within these fibrovascular cores as well as at the periphery of the duct, because it's a normal double layer of luminal cells and myoepithelial cells. So this is the underlying scaffold we'll build upon for the subsequent lesions. Now, these benign intraductal papillomas can be involved by a wide range of benign and atypical proliferations, which we'll take a look at. Now, any manner of atypical hyperplasias, ADH, ALH, LCIS, DCIS, any manner of these atypical lesions can involve an underlying papilloma. Because it's an underlying papilloma, the base architecture maintains that same structure of the benign intraductal papilloma, and it maintains the myoepithelial cells in those fibrovascular cores and at the periphery of the lesion. Notice that wherever the hyperplasia is located, there will be an absence of myoepithelial cells there because that atypical lesion is expanding and pushing away, if you will, the normal underlying architecture. All right, but within the fibrovascular cores, you'll still see those myoepithelial cells. That is atypical hyperplasias or carcinoma in situ involving an underlying papilloma. As we kind of progress mentally along this spectrum of papillary lesions, we can then talk about papillary DCIS. In this lesion, it's in situ, ductal carcinoma in situ, so we still maintain the myoepithelial cells at the periphery of the lesion, that is around the duct. That defines, DCIS, ductal carcinoma in situ. But within those fibrovascular cores now, we no longer see the myoepithelial cells. This is because it's a clonal neoplastic proliferation, and now those cells can grow, if you will, without the myoepithelial cells in that structure. Finally, we reach the encapsulated papillary carcinoma. This is also sometimes termed intracystic or encystic papillary carcinoma in the most recent 2019 edition of the WHO Classifications of Tumor of the Breast, 5th edition. They recommend using the term encapsulated papillary carcinoma. And the same holds true, this pattern, for solid papillary carcinoma, where we're now calling it carcinoma, and we now lack myoepithelial cells. They're absent both within the cores and at the periphery. All right, so this sort of progressive loss, if you will, of myoepithelial cells from being both present in the cores and at the periphery to loss or absence in the cores to absence in the cores and the periphery is how I mentally think about how I can separate out benign papillomas from papillary DCIS and encapsulated papillary carcinoma. Right, so I can bring this back up later, either in the middle or at the end of the talk, just to reinforce, but I wanted to mention it now before we looked at the slides. And I do want to make a note, because it's clinically important, that even though we're calling this encapsulated papillary carcinoma, or the other variant of solid papillary carcinoma, although we're calling them carcinoma, they appear to behave the same as ductal carcinoma in situ. And it may be that they're kind of in transition, or they lack the myoepithelial cells but still have basement membrane. Whatever the case may be, they should be staged as PTIS. So they're staged as in situ carcinomas. This is important clinically because it could be a large lesion, yet carry a very minimal, to no risk of metastatic spread. So we'll revisit this again when we look at invasive, conventional invasive carcinomas that can arise out of encapsulated papillary carcinomas. But I want to emphasize again that these pure encapsulated papillary carcinomas should be staged as an in situ lesion. Okay, so with that, let me just pull up my my images. So hopefully this is nice and clear for everybody. It's projecting from my camera on my microscope. We'll take a look at this first case. This is a core biopsy of a 35-year-old female who has presented with nipple discharge and was found to have a mass. So here we see this breast lesion on core needle biopsy, and papillary lesions on core biopsy can be challenging because they often fragment because they're projecting within a cystically dilated duct space, and you may not actually see the distinct interface with the adjacent normal breast tissue. In this particular core, we see some of the cores that show just dilated duct wall, if you will, or cyst wall, which you can see here lining at the edge with a bland lining. And it's very common actually to see a thickened fibrotic wall, if you will, or capsule right around the edge of that dilated duct, around the periphery of the papillary papilloma. And as we go to these other cores, here you see just fragments of the lesion that was within the duct space. So it can fragment and come out of the actual space. So what we see are these individual fibrovascular cores of these papillae, and we see in other areas more intact cores of tissue where the papillae appear to have fused, if you will, and almost appear to form a solid area. This is why I think papillary lesions can be quite difficult to recognize, because as they become more proliferative or sclerotic, they can appear like a solid mass, but it's important to recognize the fibrovascular cores of the papillae, and then that they're located within the duct space. This is how we can readily identify them as being actually papillary lesions, as opposed to being more in the solid tumor differential or category. So within these fibrovascular cores, we will see a variety of structures. Let's let the camera catch up to us. So within the fibrovascular cores, you will see the actual little capillaries which define the fibrovascular core. That's the vascular part. We'll see some inflammatory cells, and then we'll see the cells lining these cores. Now, because it's a benign papilloma, as I said before, we'll have two layers of cell. That lining cell in a benign papilloma is just the benign luminal epithelial cell. It can take a variety of forms, kind of low cuboidal. It can undergo apocrine metaplasia. It can be columnar. It can have more abundant secretory type cytoplasm. So that can vary, but it should be normal chromatic, non-atypical. And we'll have the second layer of myoepithelial cells that line these fibrovascular cores and the periphery. Myoepithelial cells in papillomas can also take a variety of forms. In this particular case, we see abundant pink cytoplasm that is taking more of a myoid or muscle-like differentiation. They can have abundant clear cytoplasm or be more spindled. So no two papillomas are the same. The epithelial cells and the myoepithelial cells can take different morphologic appearances, but they should both be bland and relatively single, kind of single layer till we get into the hyperplastic proliferations. So here we see the fibrovascular cores of this particular lesion. So far I'm thinking, okay, this looks like an intraductal papilloma, benign lining and benign second myoepithelial cell layer. As I come into these other areas of, again, this benign intraductal papilloma, here I start to appreciate more proliferation, and I see these glands still lined by myoepithelial cells that have started to proliferate and show this glandular proliferation within the central part of the papilloma. This is an example of benign adenosis occurring within the structure of the intraductal papilloma. That's a common change or feature that we'll see involving intraductal papillomas. And again, I like to kind of take a step back and say, okay, what's my underlying architecture, and then layer all of these other things on top of it. And then we realize a quite complex proliferation can be broken down into, fairly fundamental components. So again, as we look at this core here, this fragment of this intraductal papilloma, we see that we have, yes, the surface lining cells are bland, fairly single layer. Let me focus here. Here they're showing a little bit more clear cytoplasm. I have my myoepithelial cell component. I have pink collagenized, fairly low cellular stroma, and then I have benign glands of adenosis within the cores. As we move along this core, we see another example of the change the epithelial cells can undergo. And in this field, we see an example of apocrine metaplasia, the same type of metaplasia you see in fibrocystic changes. The lining cells of the intraductal papilloma can undergo similar changes, but the cells, again, still maintain their normochromatic appearance, bland nuclei, and this abundant pink granular cytoplasm. So this is a nice example of an intraductal papilloma with adenosis and some apocrine metaplasia. And it demonstrates how the duct lining or the edge of the lesion may be separate from the actual intraductal component when we're looking at a core needle biopsy. We'll take a look at a resection momentarily. The other thing I want to point out while we're looking at this lesion from low power, again, this is a benign intraductal papilloma, is how the lesion appears relatively pink. And I bring this up because we'll contrast it with the atypical papillary proliferations a little bit later. Intraductal papillomas often have very abundant hyalinized and sometimes sclerotic collagenized stroma within the fibrovascular cores. And because of that, and because the nuclei are not atypical, not hyperchromatic, they can appear very pink at low power. The other feature I want to mention is that the fibrovascular cores tend to be rather large. I'm at my 2x, I'll go to 4x. the fibrovascular cores are kind of large, broad-based, and they lack delicate, thin, arborizing branches. Again, this is to contrast what we'll see later with encapsulated papillary carcinoma. So benign intraductal papillomas tend to look very pink from low power, have sclerotic hyalinized cores, and tend to have very broad-based, larger branching papillae, rather than delicate, thin cores. Now, the structure of intraductal papillomas can have a variety of proliferations involving it. So we'll talk in a minute about the atypical ones. Very commonly, intraductal papillomas can be involved by usual duct hyperplasia. And I'll show an example of that here so we can talk through the differential. So this is another core needle biopsy, a 38-year-old female this time who has a palpable breast mass. So as we look at the cores, one thing I notice in this particular field is that I have this dilated duct space with something projecting into it. This helps me put this lesion into the papillary category, intraductal papillary category. Again, a slightly higher power, I see this dilated duct space with the bland lining, and it's very pink, hyalinized sclerotic stroma from low power. I'm thinking, okay, I'm probably dealing with an intraductal papilloma. As I go along the core, I notice a lot of epithelial proliferation with still maintaining those fibrovascular cores. And so we go to higher power, we're going to try and decide what exactly is this proliferation. Is it usual or is it atypical? And this particular lesion, again, maintains the myoepithelial cell layer in the fibrovascular cores. I can see this outer lining layer here. This is, again, the fibrovascular core with the vessel, the small little capillary, the fairly hyalinized pink stroma, and then these proliferating epithelial cells, which are now fusing, in essence, proliferating entirely between one fibrovascular core and another, with swirly architecture, overlapping cells, variably sized nuclei, some slit-like spaces, no monotony, and rigid polarization of spaces. This is a florid usual duct hyperplasia involving an intraductal papilloma, or you could say an intraductal papilloma with florid usual hyperplasia. If we weren't sure whether or not we have myoepithelial cells present in the core and at the periphery, we can certainly do immunostains to highlight them. And I have an example of that on this particular case. So the benign intraductal papillomas, I'll focus here. Okay, 1 second, there. Have intact myoepithelial cells at the periphery. This is an example of a dual combination immunostain for P63 that is brown, that highlights the nucleus, and smooth muscle myosin heavy chain, which is pinkish red, and highlights the cytoplasm. So here we have intact myoepithelial cells at the periphery of the papillary proliferation, and we also see intact myoepithelial cells within the fibrovascular cores. So here's a core. You kind of see the vessel highlighted delicately by the smooth muscle myosin heavy chain, and we see intact myoepithelial cells. This does highlight a few pitfalls in the interpretation of myoepithelial cell markers in papillary lesions. One is that the lesional cells themselves can sometimes label for some of the myoepithelial cell markers. We see some cytoplasmic labeling for smooth muscle myosin heavy chain, and you may have seen some lesional cells, I would say some epithelial cells can label for P63. So you want to make sure you're interpreting the myoepithelial cell labeling in the appropriate location of where the myoepithelial cell should be, which is right at the base, basal cell layer base of the epithelial proliferation, right around the fibrovascular core. The other important pitfall is, as I mentioned, these beautiful little capillaries often will show labeling for some of the smooth muscle markers we use for myoepithelial cells. So here we see delicate labeling for smooth muscle myosin heavy chain. The same goes for calponin and smooth muscle actin immunostains. I'll go one higher. And so this labeling around the capillaries should not be misinterpreted as myoepithelial cell labeling in say papillary carcinoma. So I just pointed out to you here where we can clearly see the difference. Myoepithelial cells typically show a ring-like labeling for the muscle, cytoplasmic muscle marker, like around the nucleus, whereas the capillaries have kind of thin, wispy, sort of more spindle cell-like labeling. All right, so I just point that out to you here. The other way we can use immunostains to help us in the differential of the classification of the papillary lesions is in the epithelial cell component. We can use immunostains to help us. So what happened? I lost my view. To help us decide if this proliferation is usual hyperplasia or atypical hyperplasia, and this holds true whether you're in a intraductal papilloma or in a lesion outside of a papilloma. We'll often use a combination of ER and CK5/6 to help us when we're not entirely sure if a lesion is usual hyperplasia or atypical. In usual hyperplasia, decide if the cells show just patchy labeling for ER. So some of the cells will label. This is an ER immunostain. Some of the cells label for ER and some don't. So it's what we would call patchy or mosaic pattern labeling because it's not a clonal estrogen-driven proliferation. Whereas in atypical hyperplasias of low nuclear grade are typically strong and diffusely positive for ER. Similarly, for CK5/6, we'll see kind of this patchy or mosaic pattern labeling. Let me get a nice field for you. In the usual hyperplasia, but absence of labeling in atypical hyperplasia. So this is, again, usual hyperplasia in an intraductal papilloma, and it's showing mosaic pattern labeling for ER and CK5/6. Now, the management of benign intraductal papillomas is changing. It's been changing over the past few decades, particularly in the past 5 years. This is an excision of an intraductal papilloma with adenosis and florid hyperplasia. And we'll talk about the slide momentarily. In essence, the evolution has been to move away from reflexively excising all intraductal papillomas seen on core needle biopsy to now taking a step back and saying, well, what's the radiologic pathologic correlation? If the radiologic impression is of intraductal papilloma and the core needle biopsy is intraductal papilloma with no atypia, no features of atypia, then we would call that a concordant diagnosis. In those cases, benign intraductal papillomas with concordant imaging are no longer necessarily referred for surgical excision. Those patients can just be followed. There's a low rate of upgrade to cancer in those patients. If there's any discordance, if there's any suspicious features on imaging, alternatively, if there's any atypia in the lesion, those patients are still referred for excision. So I mention that because this is a change in the practice pattern that the historic practice pattern of just excising all intraductal papillomas. Now, again, benign intraductal papillomas with good radiographic, radiologic and pathologic concordance don't necessarily require excision. This is an example of a case that was excised, and from low power, we can see a lesion that's very pink. It's pinker than it is blue, although I realize that's in the eye of the beholder. And I have to drive around the lesion to decide, okay, what family lesion am I dealing with here? In some areas I can see more clearly, yes, I'm dealing with a lesion that is projecting into a cystically dilated space with fibrovascular cores. This must be a papillary lesion. As I go to higher power, I can appreciate that these fibrovascular cores here have a myoepithelial cell lining within them and have a florid epithelial proliferation that shows the features of usual hyperplasia. Swirly overlapping cells, non-atypical nuclei, slit-like spaces. So this is, just as in those core biopsies, an example of an intraductal papilloma where I see hyalinization and sclerosis of the cores, fusing of some of the cores, back-to-back glands that still maintain myoepithelial cells. In this case, they're rather cleared out. I see mitoses, some of which are in myoepithelial cells, some of which are in the luminal cells. That doesn't bother me. The cells have to divide. A mitosis does not make this cell atypical. This is just back-to-back adenosis. I see myoepithelial cells around each of these glands. So although it's a very busy proliferation, I can break it down into its components. In intraductal proliferation, I see the duct space. I see the fibrovascular cores. I see the myoepithelial cells investing the cores as well as around each of these glands. And I have the features of usual hyperplasia within the epithelial component. So although we have a lot of features here, we can break them down and say, yes, this is an intraductal papilloma with sclerosis, adenosis, and florid usual hyperplasia. The feature I want to point out, in addition to the diagnosis, is that intraductal papillomas frequently show needle tract displacement on excision if they've been core needle biopsied before. And here in this field, we see the intraductal papilloma. And as we come out to this side here, we see an almost linear, I can use my arrow if that's a little bit like better, easier to see. We see an almost linear row of these small tubules that are almost, you can imagine, literally pulled out through this stroma in a linear row. And in each side of this fibrotic, area, we see inflammation on both sides and a hint of fat necrosis and hemorrhage. These are clues to tell me that this is needle tract displacement of these little epithelial nests and not an invasive carcinoma. If we go to higher power in these areas, I can see better that there is this chronic inflammation and reactive, if you will, fibroblasts disrupted by this injury of the needle pulling through this area, and these tiny little epithelial cells here, which resemble the usual hyperplastic cells within the papilloma right next door. They're just pulled out through because of the needle. This can be treacherous because they don't always have myoepithelial cells around them. Imagine if you just pulled out some of these usual hyperplasia cells and just pulled them through. They wouldn't have the myoepithelial cells accompanying them. So if myoepithelial cells are present on the stain, that's great. If they're not there, you have to use the clues of a linear row of cells with accompanying features of biopsy site and needle tract changes. All right, so I want to point that out there as important features. Now, I want to briefly mention two other benign papilloma variants before we talk about atypical papillary lesions. One of those that can occur in the breast is a pleomorphic adenoma or benign mixed tumor. These, when occurring in the breast, frequently arise in association with a benign, like features of a benign intraductal papilloma. Sometimes you may not see the sort of more conventional intraductal papilloma component. Pleomorphic adenomas or benign mixed tumors that happen in the breast look and stain identical to the ones that happen in the salivary gland. Here's a core needle biopsy of a lesion in the breast. We see that we're in a duct space, okay, that's my diagnostically useful clue. Dilated, lined by bland, flattened epithelium, and I have a proliferation projecting into that space. In some areas, I see what resembles more conventionally as an intraductal papilloma with adenosis. All of these glands within the fibrovascular core. I can see that each of the glands has a myoepithelial cell layer, which I'd like to get into the field for you. So I can see the inner bland luminal cell layer, the outer bland myoepithelial cell layer, and the bland stroma. What's unique about this lesion is it merges into these areas that have very prominent chondromyxoid stroma. And quite distinctly, you can see a difference between the area on the right, which shows the back-to-back adenosis, and this area on the left that shows really prominent chondroid stroma. And this is an area that is showing evolution to a benign mixed tumor, or again, pleomorphic adenoma. That's a really nice example. Another benign proliferation that falls under the papilloma variant category is an adenomyoepithelioma. And this can show also a variety of morphologic features. So and again, one doesn't always look identical to the other. But here's an example of a adenomyoepithelioma. We'll walk through it. First, what am I dealing with? Okay, I think I'm dealing with a lesion that shows a very smooth contour and some dilated space, which makes me think it must be occurring within a duct space. And I think I have some fibrovascular cores in here. I must be dealing with a family of a lesion that occurs, that is within the papillary family. All right, so now let's take a look at the actual cell types. Well, in this lesion, I'm seeing something I didn't notice before, which is a really prominent clear cell component. So if I go higher power here around these glands within the fibrovascular spaces here, it's not really well focused. I want to make sure it's nice for you on the screen. Here we go. We see the fibrovascular cores, little delicate capillaries. And now I see what looks like two different cell populations in here. Some cells have a very clear, abundant clear cytoplasm, and some cells have more pink, sort of cuboidal appearance to the cells. This is making me think that perhaps we have a proliferation of both the myoepithelial cell component and the epithelial cell component. That's what defines adenomyoepithelioma. Adeno referring to the luminal component making the adenosis glands, and myoepithelioma referring to a proliferation of the myoepithelial cell component. So now we no longer only have the glands proliferating, but the myoepithelial component of that gland is also expanded. Now they should be non-atypical, so they should be bland, not show frequent abundant mitoses, not show a hyperplasia, and not start to expand beyond the confines of this underlying papillary lesion. Once we start to see those atypical features, we kind of move into atypical categories. But this is a example of a, let me get into a field that's, I just want to make sure it's focused for you on the screen. Here we go, a little bit better with the light contrast. Example of an adenomyoepithelioma, proliferation of both cell components. We can highlight both cell components often with sometimes ER, sometimes CK56 will highlight just the myoepithelial cell component. And in general, although these are also benign, just like intraductal papillomas, these are still being recommended for excision because the long-term follow-up of leaving them in the breast without excision is not known. But surgical excision is the management, and they don't require any additional treatment. So in addition to just the epithelial cell, we have expanded myoepithelial cell component. The differential in these is often lobular neoplasia if you have ALH or LCIS involving a papilloma, because the myoepithelial cells can frequently show this cleared out cytoplasm, but all of these cells are show intact membranous E-cadherin labeling and label for myoepithelial cell markers like P63 and calponin. All right, so those are the benign intraductal papillomas and the benign papilloma variants that I want to mention right now. And then let me pull back up this diagram. This is a table summary of the same thing I'm showing here of the myoepithelial cells and the papillary lesions. So we've just talked about the scaffold, the benign papillary lesions. Now I want to shift gears and talk about atypical lesions. So ADH involving an underlying papilloma, ALH involving an underlying papilloma, and then move into encapsulated papillary carcinoma, and we'll look at some papillary DCIS. So in these lesions, we will start to see an absence of the myoepithelial cells within the actual fibrovascular cores. Okay, so let's go back somehow to my camera, and we'll take a look at this papillary lesion here. Okay, so here I have a papillary lesion on excision. It's kind of a lot of light. Let me pull it down for you. Here we go. Where I have to say, okay, what am I dealing with? I see that I have a fairly smooth contour to the lesion and a dilated duct space with this lesion within it. Okay, so I'm dealing with a papillary lesion. I see that I have really mostly pink impression from low power. I see hyalinized fibrovascular cores, and then I see a lot of areas that show benign adenosis with back-to-back glands. Let me focus for you here, where we see the myoepithelial cell layer with underlying the benign luminal cell layer around all of these glands. But as I drive around, I start to notice some areas where the glands appear to fuse in a way and appear to be forming perhaps true cribiform spaces that make me worry that I'm actually dealing with a true cribiform proliferation rather than just back-to-back glands. Notice here the cells become expanded, more uniform, more monotonous. They're making me think about atypical hyperplasia rather than usual hyperplasia. So again, in this field here, I see an expanded area where I don't definitely see that nice myoepithelial cell layer anymore. The cells are more monotonous and uniform, and I'm worried about atypical duct hyperplasia involving the underlying papilloma. In this case, if I do immunostains for myoepithelial cell markers and I go to these areas that appear to be expanded, let me find the same area for you. First we'll back out and look at the architecture. If I look at the overall architecture of this lesion, I notice that I have my myoepithelial cells intact at the periphery and intact within the fibrovascular cores. This is a smooth muscle myosin heavy chain cytoplasmic marker for myoepithelial cells. I see that I still have intact myoepithelial cells. The underlying architecture has to be of an underlying intraductal papilloma because that's the only one that still has the myoepithelial cells in the cores. Okay. Then as I move over to the areas where I'm worried about an expanded atypical proliferation, I can see that within the expanded area, I now have absence of myoepithelial cells. This expanded area could be usual or it could be atypical. I have to decide that based on the cytology of the cells, which I've already described. I favor to be atypical because of the monotony, the uniformity, and the suggestion of rigid cribiform spaces. I can use immunostains, as I mentioned before, to help support my impression in these low nuclear grade lesions. ER in atypical hyperplasias will be strong and diffuse in the lesional cells. So here we see this expanded area where all of these cells are actually positive for ER rather than showing patchy labeling like I saw in the usual hyperplasia, right? So this is atypical ductal hyperplasia involving a papilloma. The distinction between ADH and DCIS in a papilloma involving an intraductal papilloma is the same size criteria distinction that we use outside of the intraductal papilloma. I know there are a variety of them. In the latest WHO, it specifically endorses using a size cutoff of 3 millimeters within the intraductal papillomas. Whereas outside the papillomas, there are different criteria. We still use the 2 to 3 millimeter cutoff for low nuclear grade lesions to distinguish between ADH and DCIS of continuous spread. So within the papilloma, the 3 millimeter cutoff distinguishes between ADH and DCIS. All right, so here we're seeing atypical proliferation involving the underlying papilloma. That hyperplasia can be ductal, as I just showed you, or it can be lobular. Here's a core needle biopsy of a proliferation. We say, what are we dealing with here? Oh, okay, I see areas that look like hyalinized sclerotic fibrovascular cores. I see these fibrovascular cores of the papillae projecting into these spaces. But in this case, I also see an expanded layer outside the luminal cell layer, where I have to ask myself, what are these cells? Are they the myoepithelial cells, or are they lobular neoplasia, ALH, LCIS? In contrast to the cells in an adenomyoepithelioma, where the myoepithelial cells may show expanded, clear, bubbly, or vacuolated cytoplasm, ALH or lobular neoplasia cells tend to show one distinct, nice cytoplasmic vacuole. I'm showing you right here, like a signet ring cell. So one vacuole as opposed to expanded, bubbly, multivacuolated clear cytoplasm. These are single signet ring vacuoles. So this is an example of lobular neoplasia, or in this case, ALH, involving an intraductal papilloma. And we can see it in a few different areas. Again, the management of atypical lobular hyperplasia has also been evolving in the past 5 years. And the recommendation is, again, to do radiographic pathologic correlation. And if the ALH is not accounting for the radiographic finding, it's considered incidental, as it would be here. The finding is the papilloma, or accounts for the radiographic finding is the papilloma, and the ALH is sort of bystander or accompanying the proliferation. It's not leading to the radiographic findings. So in those cases, excision is not absolutely indicated for incidental, non-radiographically evident ALH. Right, so that's a change from the management in the past. All right, so these have all been lesions kind of built on the scaffold of a benign intraductal papilloma. Now let's take a look and jump to the other end of the spectrum and go ahead and look straight at the encapsulated papillary carcinomas. There we can contrast one end of the spectrum from benign intraductal papilloma to this encapsulated papillary carcinoma. Now we'll pull that up here, and then we can build upon it. Okay. So here I have a papillary, well, I have a lesion. So let's decide what I have. I have a lesion that looks to be within a dilated duct space. I see this space, I see some lining, and then I see fibrovascular cores. It's like, okay, I think I'm dealing with a papillary lesion. In contrast to the benign intraductal papilloma, I would argue that this lesion, to me, from low power, appears more blue than pink. I don't see the hyalinization of the stroma within the cores. I don't see broad-based fibrovascular cores or papillae. What I see is small fibrovascular cores with delicate branching, arborizing papillae. They're lined by a fairly single layer of cells that are quite hyperchromatic, in some areas columnar, but they're hyperchromatic, higher NC ratio. In some areas, they're more columnar than they are cuboidal. And this is making me concerned that I'm dealing now with an atypical lesion rather than a benign intraductal papilloma. When I go to look with my eyes, without using immunostains, just at the H&E, I want to ask myself, do I see myoepithelial cells in this core? I don't definitely see myoepithelial cells. I see a nice capillary, the supportive cells in the fibrovascular core, and then I see these lining cells, which are hyperchromatic and somewhat columnar in orientation here. Just because I don't definitely see the myoepithelial cells doesn't mean they're not there. So I would definitely do an immunostain here. If I did see a nice clear layer with my eye, I would feel reassured. I may not need to do the myoepithelial cells. So my differential when I look at this lesion is, I think this could be papillary carcinoma, encapsulated papillary carcinoma, or papillary DCIS, depending on whether or not I still have myoepithelial cells at the periphery. Okay, so when I look at another example, and we'll use stains shortly, another case, similar low power impression, very blue. I have a cystically dilated duct space with these projections of papillary fronds within it. Okay, I'm dealing with a papillary lesion. I think it's blue from low power with very delicate branching, narrow cores. I'm thinking that this is in our atypical side of our differential rather than a benign papilloma. If I look more closely at the cells, again, they're hyperchromatic. They often have this more columnar-like appearance, more tubular like arrangement of the nuclei, and I don't definitely see a myoepithelial cell layer. So let's keep this image in your mind. This is an encapsulated papillary carcinoma. Let's take a look at the stains. If I do myoepithelial cell markers, here's this case. This particular stain is a P63. I'll show you that it's working. Off to the side here, I have a normal duct. I see my nuclear P63 labeling around this duct. When I go to my lesion, I see that I lack myoepithelial cells inside these fibrovascular cores. Notice that there is occasional P63 labeling in the actual epithelial cell. That's just P63 labeling of the epithelial cell. It's not in the myoepithelial cell distribution, right? So I highlight that here because it's a big pitfall. As I go to the periphery of the lesion, it's starting to peel off a little bit from the wall, which sometimes happens in the sectioning. I lack myoepithelial cells at the periphery. This is an example of encapsulated papillary carcinoma, absence of myoepithelial cells within the core and at the periphery. And these low nuclear grade lesions also show strong diffuse labeling for ER, which you can see here. Again, supporting the diagnosis of encapsulated papillary carcinoma. You see this whole lesion is labeling, nice and positive. Okay. When we go back to this first example, this encapsulated papillary carcinoma that I showed you here, I have the combo myoep stains for P63 and smooth muscle myosin heavy chain, where the P63 would be brown nuclear, is absent, and the smooth muscle myosin heavy chain is red. Now, I want to bring this again to your attention that this lesion lacks myoepithelial cells. It's negative, right? There are no myoepithelial cells in these cores. What is labeling, though, again, are the capillaries. So I know it's a capillary because it's thin, walled. In some areas, they're quite small, little wispy labeling. Sometimes these capillaries become very dilated, and they can push up against the epithelium and may mimic labeling of myoepithelium. All right, so it can be misinterpreted to be myoepithelium, but as you scan around the whole lesion, you realize no, the myoepithelial cells are absent. Okay, this is important because it's a pitfall in the interpretation of these stains. All right, so this is encapsulated papillary carcinoma with absence of myoepithelial cells at the periphery and within the cores. So this is important to recognize because unlike benign intrabuccal papillomas, it does require excision. We want to evaluate the whole lesion to look for any conventional invasive carcinoma patterns, okay? This alone by itself is just staged, again, as PTIS. It's managed like carcinoma in situ. What we want to exclude is any definite invasive conventional ductal carcinoma, right? So this is solid papillary, encapsulated papillary carcinoma. I want to contrast that with the other variant, which is the more solid papillary carcinomas. And this particular example here, I see a proliferation within a duct space. Notice it has very smooth contours. I see fibrovascular cores. Say, okay, all right, so I'm in a papillary category. I'm going to go to higher power and appreciate, again, the fibrovascular cores. And in this case, I'm seeing some features that make me question whether it's usual hyperplasia or atypical hyperplasia. It's streaming in areas which resembles usual, but then some of the cells show some granularity, this pink granularity, which makes me think, could it be showing some neuroendocrine-like differentiation? That's a feature we see in solid papillary carcinoma and in some solid papillary DCIS cases. So I'm seeing mixed kind of streaming and granularity to the cytoplasm, and this variability between the granular darker pink cells and the lighter pink cells. There's some suggestion of necrosis, so I want to work this lesion up further. If I do an ER immunostain in this area, I see that, in fact, these cells have strong diffuse labeling. This tells me that it's in keeping with a neoplastic clonal proliferation. And I couple that with the CK56, which shows absence of labeling. All right, so ER strong and diffuse, loss of CK56 labeling. This is supporting an atypical proliferation. Notice that CK56 can label myoepithelial cells. It's also called a basal marker. So again, that should not be interpreted as lesional cell labeling. Now I want to see if there's any, what's the pattern of myoepithelial cells in this lesion? Is it in solid papillary carcinoma or solid kind of papillary DCIS? Here I see my myoepithelial cells intact at the periphery and in the fibrovascular cores. With this, this is showing me that I have this neoplastic process involving an underlying papilloma. All right, so I have this solid pattern DCIS involving an underlying papilloma. I'm showing this example because this type of epithelial and nuclear, or this nuclear and cytoplasmic features of the granularity and the monotony can be seen both in situ processes, just conventional DCIS classification, as well as in the solid papillary carcinomas. These lesions, as I said, based on that cytoplasmic granularity, can also label for neuroendocrine markers, and this is synaptophysin, showing the synaptophysin labeling. So this is the type of pattern labeling you'll often see in the solid papillary carcinoma variant. Okay, so we saw encapsulated papillary carcinoma, and then this solid pattern neuroendocrine pattern in situ process that can either be involving papillomas or standing alone as solid papillary carcinoma. In the last few minutes, I want to show you the what we really want to evaluate these papillary lesions for is the presence of conventional invasive carcinoma arising in association with the lesion. So as I mentioned, the encapsulated papillary carcinomas are staged as in situ, PTIS. Here we have an example, blue from low power, intraductal fibrovascular cores, hyperchromatic nuclei, thin, delicate branching. I'm suspicious for encapsulated papillary carcinoma, possibly papillary DCIS. So far, I'm thinking, okay, it looks in keeping with this proliferation, probably still PTIS. And then I see the small angulated glandular proliferation within the stroma. This is the type of lesion that you are always want to be on the lookout for when you're evaluating papillary lesions, because the patient's prognosis, the stage, and the management are going to be driven by the presence and size of any conventional invasive ductal carcinoma, or what I would call conventional invasive mammary carcinoma, no special type. Any type of mammary carcinoma can arise, in association with these encapsulated papillary carcinomas. I mean, you could see lobular carcinoma, metaplastic carcinoma, ductal carcinomas. In this particular example is of invasive ductal carcinoma. So we have this intraductal process, which has fibrovascular cores, hyperchromatic tubular appearing nuclei, delicate arborization. We can look at the myoepithelial cells and decide whether it's encapsulated papillary carcinoma or papillary DCIS. But this proliferation here has irregular glands, lacks myoepithelial cells, which we can confirm, irregularly infiltrates into the fat, and does not appear to be within a linear row of needle tract changes. Notice there are no biopsy site changes associated with this. It also does not appear to be confined to like a capsule of the periphery of a papillary lesion. That's another differential. If we look at this lesion, we can start with an ER. We can see that the intraductal papillary component is strongly and diffusely positive for ER, supporting that it's a neoplastic clonal proliferation, as is our small glandular proliferation, suspicious for invasive ductal carcinoma. When we take a look at our myoepithelial markers, we can see a variety of patterns, which is why I really like this case to illustrate to you. These ducts off to the side, the first ones we start with, notice we have intact myoepithelial cells at the periphery, but absence of myoepithelial cells in the fibrovascular core. And we've already said that these are atypical appearing nuclei, hyperchromatic, diffusely positive for ER, no myoepithelial cells. This component is papillary DCIS. We can look back at our image and remember that papillary DCIS maintains the myoepithelial cells at the periphery, but has absence in the center. The larger nest, which on the H&E really looks morphologically identical to this component we're calling papillary DCIS, the larger nest here lacks myoepithelial cells, both at the periphery and within the cores. Okay. These are the capillaries pushed up against the wall. So this is papillary carcinoma, encapsulated papillary carcinoma. Papillary DCIS and encapsulated papillary carcinoma often occur together in the same lesion. Both are staged as PTIS. Now we look over here at the small glandular proliferation. Let me make sure we can see it on the screen. Yes. we see that these small glands also lack myoepithelial cells. So I have evidence to support classification as an invasive ductal carcinoma. We'll go back to the H&E. This is important because this area is, let me see, approximately 3 millimeters in size. This patient, despite having 2 centimeters of papillary mass, will be staged based on the size of this conventional invasive component. That's a PT1A, 3 millimeters of invasion, and the papillary component is entirely staged as would be the in situ component, despite it being an encapsulated papillary carcinoma. Right? So those are a lot of words to say that encapsulated papillary carcinoma, papillary DCIS, the entire size of that is still considered and managed as in situ. Only the size of the conventional invasive mammary carcinoma contributes to the size of the patient's stage. So in this case, it would be T1A. Okay. Now, I want to end the discussion with 2 lesions that we don't want to misclassify as encapsulated papillary carcinoma. Encapsulated papillary carcinoma is occurring in the duct space, has low nuclear grade, like typically nuclear grade 1, maybe nuclear grade 2, strong and diffusely ER positive. We're staging them as in situ. So we want to be pretty sure that this is encapsulated papillary carcinoma by the books, by the definition. There are 2 entities we don't want to miscall encapsulated carcinoma. One is a true invasive papillary carcinoma. That's a rare entity and it's a different entity. Recall I said encapsulated papillary carcinoma maintains this, in general, fairly rounded, smooth architecture and is low nuclear grade. I'm going to show you an example of an invasive papillary carcinoma. Let's see here. And in this particular case, we have, back up because I think there's, yeah, perfect. Okay. So in this particular case, we see a lesion that shows papillary architecture by the presence of these fibrovascular cores, but they're in irregular nests of cells that have, in this case, intermediate nuclear grade. In some cases, we'll see higher nuclear grade, with irregularly shaped infiltrative nests, sometimes with a desmoplastic response, that go into the stroma. So features that you will use to exclude the diagnosis of encapsulated papillary carcinoma, but rather call invasive papillary carcinoma and is staged as entirely invasive lesion, is when you see irregular, almost jigsaw puzzle pattern pieces of invasive irregular nests, higher nuclear grade, and a desmoplastic response, which I'm not showing you in this particular field, but elsewhere we have. These features will put you outside of the category of an encapsulated papillary carcinoma, and you'll want to render classification as actual invasive papillary carcinoma. So irregular nests, higher nuclear grade, and a desmoplastic response. The other feature that you don't want to misclassify as encapsulated papillary carcinoma is a pseudopapillary pattern of a very high-grade cancer. So this is a high-grade mammary carcinoma, sheets of these hyperchromatic cells, high nuclear grade, abundant mitotic figures, cellular necrosis, irregular interface, irregular nests of cells in the periphery. Okay, in the center of this lesion, it looks like we have some fibrovascular cores with the cells around them. But what's happening here is we have extensive geographic necrosis, where these cells are outgrowing their blood supply and dying and only staying viable around the vessels. This is pseudopapillary. This is a high-grade, terrible, invasive mammary carcinoma that's showing a pseudopapillary pattern where the cells are dying off away from the vessels. This is pertinent largely on core needle biopsy, where you may just get the center area and say, oh, it sort of has a papillary architecture. You don't want to call encapsulated papillary carcinoma because right off the bat, you see high nuclear grade, apoptotic figures, let me focus view, frequent mitotic figures, extensive necrosis. This would be better served as saying it's a high-grade carcinoma. It shows some papillary features based on this morphology, the structure, but you don't want to call the encapsulated papillary carcinoma variant, which would be staged as in situ. So I'm going to end by putting up this nice slide again, core needle biopsy of a true encapsulated papillary carcinoma, blue from low power, arborizing delicate fibrovascular cores, no myoepithelial cells in the center or at the periphery. I always keep in my mind this particular image as let me see, you can make it bigger somehow. As I'm approaching a lesion, first identify it. Is it papillary? Is it in a duct? Does it have a smooth contour? Do you see the fibrovascular cores? And then build upon that structure. Where are the myoepithelial cells? Are they there? And is the epithelium usual, benign, versus atypical? All right, so that's the general approach in, we'll say, 65 minutes or less of an overview of papillary lesions, the benign and the atypical. And I'm happy to take questions now or later via email. I'm always available. Thank you all for your attention, and again to Rifat and Emilio for the invitation.
Thank you, Dr. Cimino-Mathews, for this excellent elaborative discussion on papillary lesions of the breast. There are quite a lot of questions online, both on Facebook as well as YouTube.
Sure.
I would be able to at least read some of them. And let me ask, I think the most recent one is, can solid papillary carcinoma and invasive papillary carcinoma be different? If yes, how do we differentiate?
So can solid papillary carcinoma and what was the second entity?
And invasive papillary carcinoma.
Yes. Solid papillary carcinoma and invasive papillary carcinoma are different. Solid papillary carcinoma maintains a very smooth contour around the ducts and is still low nuclear grade. So I'll put the example back up that most closely resembles that here. 1 second, let me close this and go back to my camera. Solid papillary carcinoma will, in essence, from H&E power on H&E look like this example of solid DCIS. It's low nuclear grade. It typically forms a single mass, but sometimes can be a few nests. But even if it shows these kind of 3 different nests, say, because it's expanding through this duct that's sort of branching this way, the contours are smooth, there's no desmoplasia, and it's low nuclear grade. Invasive papillary carcinoma has to show irregular nests that have higher nuclear grade and a desmoplastic response. So I hope that sort of helps kind of address the question, but I acknowledge and would 100% agree that it's very difficult. It can be a very difficult distinction to make, but you can always fall back on what's the nuclear grade. Solid papillary carcinoma should not have high nuclear grade. So that's one branch point. And do you have smooth contours of the lesion around the duct, or is it irregular and infiltrative?
Thank you. There is another question. I think I'm going back to the beginning of the lecture so that I can cover at least a few. So there was one question about what's the choice of immuno to be used to highlight myoepithelial cells if we don't have the dual immunohistochemistry? And
Sure.
P63, smooth muscle myosin heavy chain, high molecular weight cytokeratin, can these be useful?
Yes. So the question is, what types of immunostains can you use for myoepithelial cells? We only recently kind of created the dual multiplex stain, mostly to use in small samples, like on core biopsies, where if you did multiple levels, it might get cut through. But the bottom line is, you always want to do at least 2 myoepithelial cell markers, because some myoepithelial cells show different phenotypes. Some are more epithelial, some are more myo in their differentiation. And, you know, certain planes of section might not be cutting directly through the nucleus. So we always use 2. I know some of my colleagues always use 3 at different institutions. So at least 2. And we like to use P63 because it's an epithelial and a nuclear stain, as well as smooth muscle myosin heavy chain for a smooth muscle-like marker. The muscle-y markers are that I would recommend are smooth muscle myosin heavy chain, calponin, and smooth muscle actin. They all will label the myoepithelial cells. The issue is they all label to some degree also the myofibroblasts, the stromal myofibroblasts. So depending on the background stroma, you may have a lot of background labeling of myofibroblasts that can make it difficult sometimes to interpret the myoepithelial cell staining. I find smooth muscle myosin heavy chain to be sort of the cleanest with the least background of the myofibroblasts. But any of them are, if you will, acceptable myoepithelial markers. So as long as you're doing 2, I'd say either the keratin, a high molecular weight cytokeratin, P63 family, and then a smooth muscle marker.
Thank you. There is another question, which I don't know how it is related to the previous one. Like, so is proliferative breast lesion within papilloma has the same impact on the risk of carcinoma as the same proliferative lesion not associated with papilloma?
Yes, so that's a good question. So just having proliferative, like benign proliferative changes, I would say like adenosis, usual hyperplasia, fibrocystic changes, does it carry the same relative risk of subsequent carcinoma as if it were outside the papilloma? And I would say in general, yes, that is, yes, it carries the same relative risk, which is quite low. And for the most part, I would say if those changes are in a papilloma, they're often in the adjacent breast tissue also.
Another question is, on small biopsies, can we subcategorize into one of the 4 entities that you mentioned? And how often it gets correlated on the final histopathology?
Yes, so on core needle biopsies, it is possible to make these classifications. So for straightforward papilloma, definitely you can make that classification. And if there's good radiographic concordance, it will be still intraductal papilloma on the excision. You can distinguish between these other 3 entities, DCIS in a papilloma, papillary DCIS, and encapsulated papillary carcinoma, but you have to have the periphery of the lesion to be sure if it's papillary DCIS or encapsulated papillary carcinoma, right? If you don't see the periphery, the interface, of that, the wall of the duct, then if you can't do the immunostains to tell if you have the myoepithelial cells there, you can't necessarily distinguish between these 2. In those circumstances, if all I see, say, are the fronds, and I know it's at least papillary DCIS, the differential is encapsulated papillary carcinoma, but I can't evaluate the periphery, then I'll say something to that effect of, either atypical papillary neoplasm, and a note, these are my differential, I can't tell because I lack the periphery. It should be excised for definitive classification. Or sometimes I'll say at least papillary DCIS, see note, it could be encapsulated papillary carcinoma. And then it, in general, that's what we'll see on the excision, with the caveat that what we're always trying to make sure we don't miss is the invasive, conventional invasive mammary carcinoma. On a core, the distinction between these two, papillary DCIS and encapsulated papillary carcinoma, is not as crucial in the sense that they should both be managed as in situ carcinoma. Some surgeons may be more inclined to take a sentinel node if you're calling it encapsulated papillary carcinoma, but remember, that's really not necessary since you can stage it as PTIS. So, I try and be as precise and as definitive as possible with what material is present on this slide.
Thanks. There is another question on how to differentiate intraductal papilloma from other neoplastic papillary lesions on a core biopsy. How do you report them?
So it's possible to make a diagnosis of intraductal papilloma if you're seeing the features, as we discussed, of the benign epithelium, the broad-based hyalinized cores, and the intact myoepithelial cells in the cores and at the periphery. Even if I don't see the periphery, if I'm just seeing fragments of papillary fronds, all of which are benign lining and intact myoepithelial cells, I can say fragments of intraductal papilloma, for instance, and that's enough for the radiologist to correlate with what the radiographic findings are. Once I identify a lesion as being intraductal and papillary, then I will evaluate, okay, what's the cytology of the cells? If there's a proliferative component, if it's monotonous versus heterogeneous and streaming, and then do I have the myoepithelial cells and where are they? I hope that answers the question, addresses the question.
So there are a lot of other questions. Maybe I can take one more from here. Let me check. If both encapsulated papillary carcinoma and invasive papillary carcinoma is present in a lesion, which grade should be mentioned in the report?
So the question is, if both invasive papillary carcinoma and encapsulated papillary carcinoma are present, what should be mentioned in the report? I would describe all the grades that are present. What I would say is, in general, invasive papillary carcinoma and encapsulated papillary carcinoma don't tend to occur together, because invasive papillary carcinoma is a high-grade lesion, and encapsulated papillary carcinoma is a low-grade lesion. In general, there are two different neoplastic pathways, one that's the low-grade pathway and one's the high-grade pathway, and it doesn't typically progress from low-grade to high-grade. They're like separate highways. But if there were, sometimes you'll see two clones of the DCIS, for instance, then I would say that, I have a high-grade, grade 3 invasive papillary carcinoma, and it measures this. In the background, there appears to be grade 1 encapsulated papillary component, something like that. But it's the higher grade lesion in that setting that will drive the prognosis.
One last question.
Sure.
How will you differentiate globoid cells from myoepithelial cells?
How would I differentiate globoid cells from myoepithelial cells? I guess I would have to ask what context of the globoid cells. That's, in my mind, like a descriptor. If you're referring to a change within the epithelial cell that looks very clear, clear, abundant, clear cytoplasm, then I would say you're immunostains for the smooth muscle markers will help distinguish between whether it's a luminal secretory mammary cell versus the myoepithelial cell, which would label for the smooth muscle markers. I hope that kind of addresses that calponin, smooth muscle myosin heavy chain, and looking at the pattern, if it's basally oriented, linear, lining the epithelial layer, like below the epithelial layer.
Thank you so much. I think there are quite a lot more questions. I'm sorry that we won't be able to address these questions at this point. Hope some of the questions Dr. Cimino-Mathews could address to our viewers. And once again, thank you, everyone. And Dr. Cimino-Mathews, you would be so delighted to know that you had 1,000 viewers from across the world. And in fact, I kept account. At least I could find viewers from 52 different countries. We had viewers all the way from Bangladesh to Bolivia to Taiwan to Ecuador to Palestine, to name a few. And of course, we had viewers from US as well. And thank you all our viewers for joining in, and we appreciate your support. And if you like our lectures, please don't forget to follow our Facebook page, that is Pathcast, and also please subscribe to our YouTube channel, that is also Pathcast. And in fact, if you can click on the bell that is next to the subscription button, you can actually get all the notifications for upcoming lectures. And thank you all for joining in. And thank you, Dr. Cimino-Mathews, for your time. And
no, it's my pleasure. Thank you all for thank you all for joining, and I'll see if I can log into Facebook and see some of the other questions over time. Sure. And please, everyone is always welcome to email me. Thank you again.
Thank you. Thanks so much.
Bye.